Hi everyone, if you're just logging on now, we're just waiting 10 to 20 seconds to get enough people logged on and then we'll start tonight's webinar.
Good evening and welcome to this evening's webinar brought to you by the Australian Centre for Value-Based Healthcare at the Australian Healthcare and Hospitals Association and Wild Health. I'm Kylie Woolcock, the CEO of AHHA. I'd like to start by acknowledging the traditional owners of the lands on which we all meet. I'm joining you from the lands of the Ngunnawal people and pay my respects to elders past, present and emerging. I'm joined by Jeremy Nibbs from Wild Health and Medical Republic, who will be facilitating tonight. Jeremy.
Oh, thanks, Kylie. Good evening, everyone. I'm Jeremy from Wild Health and Medical Republic, and I'd like to welcome you to tonight's webinar on strengthening Medicare. How do we redefine the roles of primary and acute care to drive value for people, communities, and the system? Around the world, the presence of a hospital is often considered the symbol of access to healthcare. Any suggestion of a closure attracts community outcry and becomes the focus of political campaigns. But there is clear evidence that much of the care in hospitals would be better provided out of hospital. This has been aided by a rapid expansion in enabling seamless data sharing technology. Yet any shift in how we provide healthcare and how is not straightforward. And there can be a cascading impact on other health services and the community that we need to consider carefully. Tonight, we've got an expert panel to discuss how in Australia we might change the generally accepted narrative around the role of institutions like hospitals to be about to have them focused on achieving health outcomes and care experiences that matter for individuals and community. Tonight, our panel includes Hans-Erik Henriksen, who's coming to us all the way from Denmark. Hans is the former CEO of Healthcare Denmark and the CEO of Epital Health today. Dr. Rob Grenfell, Chief Strategy and Regions Officer with Grampians Health in Victoria. Leanne Wells, Director of 89 Degrees East and past Consumer Advocate Forum. Kylie Woolcock, CEO of the Australian Healthcare and Hospitals Association, and Olivia Pantadelis, the Executive Director of Strategy and Planning from the Victoria Department of Health. As we go along tonight, please use the Q&A button if you want to ask questions, and we'll try to get to those questions. But we only have an hour, and if you're interested enough, then think about coming to the Canberra Summit, which is a workshop and a full day on May 3 and 4. To give us an interesting starting context tonight, we're lucky enough to have the former CEO of Healthcare Denmark, Hans-Erik Henriksen, who over the last 15 years or so was involved in the transformation of the Danish healthcare system, including redefining the role of hospitals in order to optimise their relationship with care in the community. So my first question is to Hans. Hans, Denmark has a lot less hospitals than it once had today, and many of them have significantly changed what they focus on and how they engage with the wider community in terms of healthcare infrastructure in your country. Can you take us through a quick summary, and by quick we're going to give you 3 to 4 minutes, of the key changes to the system and the relationship in the last 10 years, how Denmark managed to successfully make these changes, and in particular, how it managed the political and community engagement, the obvious political and community engagement issues with doing something like this.
Thank you very much for the introduction, Jeremy, and I'll try to take you through the story in 3 or 4 minutes. Just to set the context, you should be aware that the Danish healthcare system is a public healthcare system focusing on universal coverage, free and equal access to healthcare, and specifically financed by general taxes. That means that as a Dane, when you have paid your taxes, it's free to go to the general practitioner, to hospital, to clinics, and that's an important background. Also, the structure of the Danish healthcare system is more simple than in many countries. We have 3 levels. We have the national level with the Ministry of Health and their boards and directorates. We have the regional level with our healthcare regions. They are the provider organization of Denmark. All hospitals are owned by the public, also outpatient clinics and emergency rooms. And we have the primary sector, which is municipalities and DPs. DPs are private enterprises in Denmark. So if we go 20 years back, we suddenly got long waiting lists in the Danish healthcare system. And that is a problem with a public healthcare system like ours, because in a public healthcare system, when demand goes up, you don't have any automatic inflow of more money and more capacity in the system. So what happened was that the waiting list problem got so severe that the government had to do something. And what they chose to do was to use private healthcare, which is very tiny in Denmark, but we do have some hospitals that proved out to be very expensive. So that kind of stirred the thought saying, hey, this is not sustainable. The solution to the problem we have with increasing demand is not to use more private healthcare services, nor is it to build more hospitals. But because if we go on that path, we will soon run out of tax money to pay for the healthcare our citizens want. So that created a focus on two structural changes. One was the structural change of the whole healthcare system. So in order to carry the transformation, the counties, which were the regions of that time, were merged from 14 counties to 5 healthcare regions. And the municipalities in Denmark, 271 municipalities, was merged from 271 to 98 municipalities, creating bigger organizations in the healthcare system, more able to carry transformation. Also, and very importantly, the role of the municipalities changed. Before, the municipalities had the responsibility for elderly care. After the reform in 2007, they have now the responsibility for elderly care, prevention and public health, and also rehabilitation out of hospital. So that was one action. The other action was to focus on the role of our hospital, because the first action was to move healthcare closer to the citizen and to deliver more healthcare through the municipalities and primary care. Obviously, that will change the role of the hospital. So a hospital commission was established, and they worked on looking at the future hospital landscape of Denmark. They reached the conclusion that we need a strong specialized backbone of hospitals, and we need to change the role of every hospital in Denmark. So if you look at our hospitals, in 2000, we had 98 hospitals in Denmark. Today, we have 30 hospitals. And it isn't that we closed 68 hospitals, we closed 25 or so. But the rest of the hospitals, they changed their roles and they were merged. So imagine if you had a city with 4 hospitals, they would be merged into one logical hospital. And if you are a hospital CEO, you could probably also imagine how much efficiency you could create from that process, because operating 4 hospitals as one hospital organization with 4 locations allow you to say, okay, then we won't have 4 places with orthopedic surgery, we will have 1. And that was part of the process. So the 30 hospitals today, it's around 60 locations, but the change has driven a lot of efficiency in the Danish hospital system. Over the last 10 years or so, we have increased efficiency and productivity with 30% in the hospital sector. Part of the game has also been asking every hospital CEO to focus on productivity, but also to use the new construct to increase the number of outpatient procedures. So every time you have an inpatient procedure, you should think about, can we do this as an outpatient procedure instead? And remember, when you increase the number of outpatient procedures, you suddenly have the municipalities with a responsibility for rehabilitation in the home of the patient. So how did we make this happen? That was also part of your question, Jeremy. One of the leading politicians in Denmark once told me, if you want to make change, don't do it as a politician. Appoint the leading experts who know what it's all about and who everybody respects, and make them work with the proposed change. And that was exactly what happened. The structure commission was led by a group of experts, the commission looking into the structure of the healthcare system, changing the regions and the municipalities. And it actually went very well. I think it was only 2 or 3 cases where municipalities refused to merge. Everything else went smooth. Likewise with the hospital commission, and both commissions worked in parallel in 2005 and 6. Then there were hearings from experts from the hospital system and also for politicians, but also public hearings. And then the structure reform took effect 1st January 2007. Right after that, we changed to regions. The hospital commission started to work with the regions, because with the newly formed regions, obviously you would have previous boundaries between the merged counties, where you had hospital close to each other, where it made sense to merge. So the hospital commission could actually just enter in dialogue with the newly formed region and say, hey, we can see you have 2 hospitals here. What are your thoughts on them? Oh, we will merge them. Great, tick. That's okay. So the main job of the hospital commission was to find out where will we have the new super hospitals, because with the hospital commission, an investment for 16 so-called super hospitals, highly specialized hospitals, was part of the game. 8 of those should be greenfield hospitals placed close to highways, infrastructure where it's easy for patients, staff to get to. 8 of them would be refurbishing existing hospitals. So the main job of the hospital commission was actually to place those big hospitals across Denmark, so we have universal and good coverage for specialized access from our patients. So yeah, I think you're on mute, Jeremy.
Jeremy, you're on mute.
Sorry, so apologies, everyone. One of the things we spoke about, that as this process proceeded, it was very quickly realised that the primary care community was quite disconnected from the hospital community in terms of communications, and that people quickly turned around to basically install a completely new technology base in that community. Can you just quickly tell us about that and how much that, how important that was to the success of being able to do what you did with hospitals?
Yeah, but that has been fundamental, and that has been a very important piece of the transformation. Actually, the digital journey of Denmark goes even further back to 1995, when one of the leaders in the counties we had at that time, he made an analysis, and he found out that doctors and nurses spent around 30% of their time handling paper. And he kind of thought, oh, well, now it's the PCH. Why don't we think about exchanging all this information electronically, so we get rid of the paper and potentially we could save those 30% of staff time. So he went to the Ministry of Health proposing a health data network, and the development on that path started in 1995. By 2003, every prescription, every reimbursement, every referral was flowing electronically, and so were lab results. And then somebody thought, if we have all this electronic information, why don't we think about making this available for our clinical staff and the citizens? And that was the starting point of the National eHealth Portal, which went live in 2003. So today, every clinical professional in Denmark who have a patient in treatment, and by that way, every citizen can look up their full electronic medical record, see all clinical notes from hospitals, clinics, GPs, see all lab results, referrals, follow the clinical pathway. So there's full transparency, and as you're hinting to, Jeremy, obviously that is a fundamental prerequisite for making the changes we're doing in Denmark.
And so that's, if you're in a primary care group, and I know there's some other patterns to that in Denmark which are different. If you're in a primary care group, you're real time be able to see someone where they've been and what everything in longitudinally what's going on in real time when they're back out in the community with you.
Yes, you're based on where we are now. You are able, if you get a patient in a GP practice, for instance, If you look up the medicine list in your GP EMR, and by the way, we have 100% coverage in Denmark, you will see all the medication, because medication is replicated back to the GP system. So there's fully transparency there. You can also look up the hospital record of the patient, so you have a full overview of the patient's clinical information. What we're working on right now is improving the clinical pathway. We're working on a tool where you can also, and that's probably what you're asking about, Jeremy, you can also see what is the planned pathway of this patient, where is the patient on the journey based on the actual diagnosis. So we are still taking steps to make this perfect.
Yeah, I'm asking because we're, as you know, we've discussed it, we're a federated system, essentially states run hospitals. The federal government runs primary care, and they're funded separately, and a lot of the funding is fee for service. So it creates quite a disconnect. But there's a significant disconnect between a hospital and a GP practice in Australia technologically, which are going to take us some segue to ask you something, Rob. Interestingly, the last RACGP annual conference, I don't know if you went to it, but GP delegates were fawning over the main speaker, also from Denmark, who described being a GP in Denmark and how GPs were hyper-connected to a very organised system, which is what Hans is describing, an organised hospital system, and it was all connected with the intent of value-based care in the community first, and then optimising what journeys go to hospital. The interesting point, which you might pick up later, the GPs are all on salaries in Denmark, and that's certainly not the case here. You're a GP, but you look after the strategy in tertiary care and to some extent the primary care in the region of Victoria, in the Grampians. Do you think the Denmark experience is a bridge too far for Australia, given our federated system of healthcare management and the other political issues that go along with that? Or do you think we should be taking seriously the idea that while we will always need hospitals, both state and federal governments should be developing strategies which go down the path Denmark is a long way down?
Yeah, look, thanks, Jeremy. Music to my ears, Hans, your journey, but I also feel the pain of the length of the journey. I just sort of probably ask these as some questions really of myself, Jeremy. Like, you know, let's first look at why would we do this? And it's pretty obvious to all of us. One is to get better health outcomes and more care efficiency. That's pretty simple, isn't it? What's the problem I'm looking at? So I've now stepped into the state health system and looking at strategy. And a couple of things Hans said, you know, one, we've actually merged 4 health systems. So we're actually consolidating. And to give you an idea where the Grampians region is, go for the west part of Melbourne and then head in a wedge all the way to the border. So we've got major regional centre Ballarat through to very small centres such as Edenhope. So population just under 300,000, and we're looking at that. The health outcomes, if I think of the chronic disease flavour, cardiovascular, we're about 3 times worse than the state average, and people hitting the cath lab have advanced disease, which means the prevention's not getting to them, which is a major problem. And my problem is I've got 3 master plans, Jeremy, where I have to actually look at what the facilities are going to look like. And I'm holding back all the people saying, oh, we need to build a new hospital, because do we? And Hans has certainly given us some good food for thought there. So I'm not going to say there's sort of 4 of the reasons, one of the reasons, and you've outlined some of those as to why it's not happening. One, the funding. Funding models are stopping this from actually happening. The second is that workforce in one area, we really haven't defined who's doing what and where, which we all think we know what we're doing in our part of the system, but it's certainly not working as a team. We're working really, some of us are playing different football codes, I think, on the same field is probably the best way to describe what we're doing at this stage at the moment. And the other one is that we actually don't have a formalised way of how we're working. Now, I'm not going to be completely negative or positive here, okay, Jeremy? The other one is the operational supports, which you actually did sort of outline. One is the infrastructure. Is it right for actually the future health system? And the second is, where's the virtual component? And I saw through the questions people are starting to ask about My Health Record and other things, and we've had this long challenge of digital, haven't we? So how could this happen? And again, feeling it, almost quoting you, Hans, word for words, but I wrote this down before you said it, but was focus on the patient care objectives and put all of our difference aside. Wouldn't that be great if we actually all worked as a team? So that would be terrific. The other one is consider where success is occurring. And the one I know well in Victoria is cancer care. We've had 2 decades of trying to systematise the care, where now one of the problems we're dealing with is survivorship. And in particularly saying breast cancer in our state, you really have to fight the system not to get evidence-based care that's personalised. And that's really exciting. The tragedy of this is GPs have been marginalised from this system, which is one of the problems. But on the other side of that is that needs to be addressed. And we now know where the holes are in the system, what needs to actually be bolstered and fixed, because we've got this accountable data. So I just sort of finished with a couple of questions on this. About, you asked me, why should Australia pursue this? Obviously, yes. But can you imagine if the dollars followed the patient? For certain conditions and others. We're doing this with NDIS and we're seeing that there's some teething problems, but hey, wouldn't that be amazing in one sense? So we don't have to actually worry about where it is, that we know what's going along with that certain person. Imagine if the IT systems were all linked and talking to each other and spreading through. That would be fantastic. Imagine if the clinical system was standardized. So if everybody who has a heart attack or everyone who has chronic heart disease in this country was receiving evidence-based standardized care. Okay, we're doing this with cancer people. And we had transparent performance metrics, which were actually displayed on how we were or weren't performing. We're doing this with cancer. Okay. If the right provider saw the patient at the right time, that would be a miracle, and that would be amazing as to where we are. Now, okay, I've been a GP, I'm a public health physician, I've worked run my own practice for 13 years in an isolated rural area, and I've worked writing policy in government. And I have to say that we've got too many examples of the wrong person is seeing the patient at various many times to optimise efficiency. And can we imagine if care was provided in the relevant setting? Because that's actually from a state health perspective, is what does the hospital look like in the future? The virtual hospital, the future hospital, the hospital without walls, the hospital that actually extends into the community is certainly a vision that I would actually hold. And maybe I'm deluded, but I'm certainly thinking that that would be a far more effective. And Hans has given us a great example of how this transition has occurred. So Jeremy, complex answer to your question, but hey, this is a complex, wicked problem.
Yeah, I agree entirely. And I think as one of my takeouts from what you're saying is, yes, we should pursue it. And you've given us 3 very big problems. The first one, if the dollars follow the patient, which seems to be a funding problem, which is a big mid to long-term problem. IT systems, a problem that we feel like timing-wise we're getting near. And then a clinical standard clinical system, that coding system that talks to each other. They don't, I just quickly, before I move to Leanne, given the timing of where we are and that we've maybe got like governments now, at least on the mainland, it feels like the timing might be right to have a go. And just, this is a very quick question, Rob, very long question for a quick answer, is do you think, because a lot of what seems to be, Denmark is not federated, so it's one group of people with, and I think quite a bipartisan governments, and probably the government, you can tell me later that, Hans. But with Australia, do you think that there's a potential for a region like yours to be managed in one line, meaning tertiary, primary, allied, all within one region? So you're in one region reaching out, trying to do your best, because there's a point where you can't get to things and you're not a part of the funding of GPs and stuff. Do you think there's a political will to try and solve that problem, which is, essentially created by the funding setup of Medicare years ago, and also by the federated system?
Yeah, look, I'm, as a practitioner, I'm morally obliged to actually provide better care to what's actually occurring here. And frankly, I'm frightened. And I used to, and Leanne knows that I used to say, if people are dying in the street, are they? Is it urgent? People are. People are actually dying of preventable diseases. And we're at this stage, we're a rich country, inequity here. So I believe that we actually need to do this as the imperative in that setting. On the other side of joining these things together, I'm a big fan of actually solving the problems at the local level. So in a regional perspective is say, we're going to actually do this, and government do you want to come along with us? We've been pushed into the corner like so many regional rural places. We are looking at towns without GPs. So it's a matter of actually rebuilding the primary through to the tertiary systems and seeing what we can do. The interesting thing, and Olivia, please close your ears, is that often there's enough money in the system, it's how we're spending it. And we actually need to look at how we're actually doing that. I totally agree with my GP colleagues. There's not enough money in that part of the system for you to do what you really want to do. And that's a decades problem that needs to be rectified. But the part of that is how could we do this demonstration? We've done it with cancer. Let's do it with something like cardiovascular, which can be systematized and then start to move across other conditions. So we could measure that. So I guess, look, I'll come back to this. Clinicians, we're morally obliged to serve our communities and make their health better, Jeremy. It's that's what drives me.
Yeah. So swapping over to you've mentioned that follow the patient, follow the money with the patient. So we're going to ask Leanne something now, which is really around the consumer side of stuff. Favourite old story, Leanne. I used to be once I was a journalist on electrical engineering publication when I was very young. Went to Tasmania, this is a long time ago, to interview the Hydroelectric Commission about energy policy in that state, and very quickly realised that the state was run by the Hydroelectric Commission because there was so much money flowing through it, and it wasn't an energy organisation. It was a group of engineers building dams who didn't know how to do anything else. Now, I'm not saying states are like that, but every state politician loves a giant new shiny hospital, especially as they're coming up to an election. And for really obvious reasons, if you're going to threaten, not putting a new hospital up, or if you're even going to say we're going to take a hospital away, you're going to have massive problems with consumers. We look at the problems we have with the gambling lobby, and I shudder to think what sort of problem, because this is a very real, heartfelt problem. How do you think you could possibly convince the public that more smaller, well-organised hospitals, maybe even less, might actually be a lot better for them in the mid to long term?
Yeah, look, I think you're right about the shiny new hospital syndrome, Jeremy. Look, I think it's always important to have the community on side when you're talking about policy and investment decisions relating to healthcare, because people vote. It's that simple. And, the election cycle, every election cycle that comes and goes, we know that healthcare is right up there as one of the top concerns for people. I think the other point I'd make is we're always going to need acute and emergency care. We shouldn't pretend that we won't. And if anything, the community needs to be assured they've got every right to be assured that acute and emergency care is going to be available to them. So I guess we need a more mature conversation and engagement with the community, don't we? We really shouldn't be engaging with the community on this topic in binary terms or with binary propositions, hospitals versus community or home-based care. It's got to be more sophisticated than that. So I suppose what I'd say is what we do need to change is the public discourse. And we really need to start engaging with communities. And I totally agree with Rob. I think the point we need to do this is at the local level, where there's deeper knowledge about what service architecture exists and where there's scope for bottom-up integration and reform. So I think the question we need to ask is, what kind of a health system is needed to serve 21st century needs? And in some ways, we need to be setting agnostic. As I said, it's not about hospitals versus general practice and care. We need to embark on an educative conversation. And that's a conversation with not only the community, but you talk about your background as a journalist. It's about an educative conversation with others in the community that shape community opinion, particularly the media, about the modes of healthcare delivery and the health system that will best serve the demands on it and the disease profiles that we're dealing with now and into the future, and what that means for the investment mix or skew. And I think reflecting on Rob's comments too about general practice now, even though it's not about hospitals, now is a really good time, the discussion, because I think public concern about GP shortages, practices struggling with sustainability, people who've been routinely bulk billed suddenly finding they're no longer, and that's not going to be reinstated. That's really reverberating with people. So while it's not about hospitals and the big red cross, it is about healthcare, and it's raising the public's consciousness about healthcare. So it's a really sobering and sort of powerful mobiliser when towns, and even big towns, big regional towns, suddenly find themselves looking around. You know, it might be, you know, hospitals under threat, but when they see GPs closing their doors, that's powerful, because towns and townships suddenly start to think about, wow, what does this mean for our town? What does this mean for our economic development if we don't even have basic healthcare? So that's a pulse in the community right now. So I think the final comment I would make about, you know, how do we convince people, is we convince by involving. And I just reinforce Rob's point about, I'm a big fan of place-based approaches to reform, integration, change as well. So we need to get the right people around the table, you know, local government, clinicians, community leaders, public health system, private system, to really unlock the possibilities. And I think there's pivotal roles here, absolutely pivotal roles for primary health networks and LHDs to work together with communities to plan, design, co-commission, and really unlock what some of the hospital of the future thinking might be. You know, a fantastic report from probably 10 years old now, and I always remember reading, and it stayed with me, from the King's Fund about the concept of the hospital without walls. You know, how can we make, it's not about the setting, as I said, it's about the workforce and the mix of clinicians and how we bring them together differently. So how can we use the specialist workforce more cleverly? We don't want to get them locked up behind, you know, behind the brick wall of a hospital. How can we get them outreaching and working as specialists and consultant advisors to boost generalism, so that we've got a more sustainable backbone to our health system, which is primary care? So I think bottom line, we convince by involving, and we take advantage right now of the heightened public consciousness about the state of play in general practice. Jeremy, that would be my thoughts on that.
I'm going to admit to being a huge cynic of, you can convince the public to turn around and accept we're not going to put a hospital up the road. And I think, and I'm just going to get Hans to give us a quick anecdote, because it feels like Denmark just leant out, and they couldn't, at the beginning of what they were doing, they couldn't get the public over the line. And I think that's for really obvious reasons. Can you just give us a quick shot at that story of what happened and how eventually the public came around, Hans?
Yeah, I'll be happy to do that. And obviously, as you're hinting to, Jeremy, the first couple of times a local hospital was closed, there was a public uproar, and also the first couple of times the politicians back down and say, "Oh, okay, you're going to keep your hospital." Then 1 year down the line or so, the local community discovered, yes, the hospital is still there. It's still a hospital, but now it has a different role. It's either a long-term internal medicine or rehabilitation hospital. So when that had happened a couple of times, some politicians did a study, and they interviewed local communities and said, if you could choose between going to a hospital within 5 kilometers, and when you get to that hospital, you will know that they had a patient like you 1 year ago, compared to a situation where maybe you need to go 40 or 50 kilometers. When you get there, you know that they are highly specialized, that they had 10 patients like you last week. What do you prefer? And everybody said, clearly, I prefer the specialized top quality treatment. I don't mind going the distance. I just need to know that when I get there, I get the optimized treatment. So that's eased the situation. Not that there's still issues. There always is when you close down a hospital, but it's not as alarming as in the beginning.
Can I just ask a question? Has there been a change of government in Denmark in the whole period of like the last 15 or 20 years? And if there was, is there then bipartisanship between changing governments on the healthcare strategy?
I think we are in the fortunate situation compared to certain countries that the different parties in Denmark agree very much on where we're going with healthcare, also based on the success we already seen. Actually, in fact, yesterday the government established a new commission to look at the next steps in strengthening our primary care system, and that has been unanimously agreed by all parties. An interesting situation was in 2011, where we got a social democratic government, and even though there's a good agreement about where to go, there's of course also differences. One difference between the liberal parties and the social democratic parties is that the social democrats do not like private healthcare. So when they got into government in 2011, they immediately closed the lid on private healthcare. The interesting thing was nothing happened, because in the meantime, the productivity gain was enough to absorb the reason which was originally why we opened up for private healthcare. Now we're doing the same. Right now we're in a situation where we use more private healthcare, but that is related to the COVID-19 pandemic and a backlash from that time.
Yep. Kylie, a big chunk of the Australian Healthcare and Hospitals Association work is around transitioning the system to value-based care. And in that, you work a lot with a lot of hospitals, which seems a little counterintuitive, given how much concentration we have on acute care and the disconnection to primary care. You'll know probably, but it stands out a couple of years ago, the CEO of St Vincent's wrote, or he was interviewed by the ABC, and he said, in a long series of arguments, we need less hospitals, not more. And I'm sorry, I'm obsessing on hospitals, and I agree we need hospitals. But we keep building. Since then, we keep building more and bigger hospitals. I'm going to be a little unfair. One is, where do you think the line in the sand is where we walk backwards? And in a sense, I'm trying to understand, it feels like we need to be, if we wanted the public to come along, we need to be pretty bipartisan and have agreement among states and agreement amongst the feds. So in a manner, the consumers have to take a few things that they may be uncomfortable with to start with. So what do you think?
Thanks, Jeremy. You're right, value-based healthcare is sort of the centerpiece of what we advocate for, and that's because it really is about that framework that brings together all those many, many stakeholders that we've been talking about, bringing them together around improved outcomes that matter to people and communities, and consider that full care pathway. So it's not just about hospitals, and I could echo what Rob and Leanne have said already, about place-based solutions, and that being the important starting place. And we do often talk about that goal of right care, right place, right time. But then what we often see, and particularly in the media and in political opposition, is that we revert to these single measures of input when we assess healthcare. So we see bed numbers reported, or we see hospital numbers, or we see, even the Royal Flying Doctor Service in their recent report about equitable access said we need more measures. It's not just about geographical distance to a building. Even numbers of doctors and nurses, and I've seen questions coming through about, the roles that different members of our health workforce can have. So we know that they're all important, but what we also know is that inputs don't necessarily equate to outcomes. So as we see these advances in technology and the roles in healthcare emerging and changing, how care can be delivered also changes. Yep. So we need to really think about what is that measure of healthcare that we're, what is that measure of access to healthcare, rather than focusing again on those, inputs. And that will allow different ways of doing things and enable that innovation in those place-based solutions if we're measuring things differently. And we've seen some positive, concerns around that line in the sand with things like that wellbeing framework, the Treasury are pursuing. If we measure things differently, we will have that mechanism to allow that innovation to occur. But it will be around some of those place-based solutions. And we do need to be careful. We saw just the King's Fund released a report last week around their shift in numbers of hospitals. And I think they report that in the past 30 years, they've gone half the number of hospitals. And that's through both, reducing length of stay and policies that provide care out of home, which are all things that we're talking about and that technology can enable better. But they're now questioning whether they've gone too far and forgotten about the purpose of hospitals that we've also raised here today, that they are still needed for urgent and emergency services.
Yeah, well, we've obviously got a big, as wicked type problem, as Rob has been talking about, and we're just touching on the surface of it. Olivia, you have a unique perspective because we have a federal system, hospitals are state responsibilities, primary care is federal. The funding for both is separated. The funding doesn't encourage that much cooperation. We see what some people describe as LHDs that run hospital regions working very closely with PHNs, but still very focused on, because of how they're funded, on what they have to do. You're at the state government level, you're at the top of that level looking at that perspective of that problem. Do you think you can give us an on the ground, I know it's a hard question and it's a politic question, but an on the ground view from a state government? Because it's not like state governments aren't trying and don't want everything to, all this stuff to happen. Can you give us some sense of where state governments are thinking and how they're thinking of working with the feds and with other state governments on this problem?
Yeah, thank you. And Rob, I don't need to close my ears because I agree with you. I think that what we have is a need for the way we allocate resources and also within that funding. So there's always work to do. So I definitely agree with you in that context. So in Victoria, particularly for the Department of Health, we have a vision of Victorians being the healthiest in the world. And that's a really powerful and ambitious vision. But when you think about that in the context of a federated system, what does that mean at a state level? And so within Victoria, and we've seen it through the huge demands on our hospital system, the establishment of priority primary care clinics, and they've actually been funded by the state government and are being rolled out across Victoria. So that was a deliberate step into primary care that the state government has taken. And now there's a broader rollout of those clinics where we're working collaboratively with the primary health networks, because this is an example of where we understand that the funding levers are separated, but we're willing to work together to try and deliver on those outcomes. Because in order for us to achieve those outcomes for Victoria, the funding and the service delivery methodology need to be able to align. We have another really great example that was established through the pandemic around COVID positive pathways. So through the entire pandemic, as we were rushing to try and understand the best ways that we could get care to people, we established a care pathway which really focused on the outcome first, and then established the model of care and the service delivery through that. And then the funding was decided after that. And so if we continue to look at barriers around our funding as the end state, then we won't be able to achieve those outcomes. So as a government department, we are dedicated to trying to work through this. We see our hospitals under pressure. We see our communities actively engaged in this discussion about more hospitals. And Leanne, I fundamentally agree with you. The conversation does need to shift in the community, and that's a challenging shift to take, and particularly in the construct of large waiting lists, people not having access to GPs or not even being able to get into an emergency department when they need it. These challenges can also be seen as an opportunity to work through those problems and start having some conversations with the community about opportunities for care closer to home. Part of our strategic intent is about continuing to design stronger services that are closer to home, that we building on our community health. Over the pandemic and through these last few years, Victoria has set up its first local public health units. Prior to COVID, we did not have public health units, and they are tasked with prevention and population health and keeping people safe and well in their communities as well. And these are really important parts of it. And it's, there are also examples that we're seeing where Victoria is leading the way, particularly in the context as well of value-based healthcare, where delivering outcomes that matter to people and populations. The Victorian Heart Hospital, which has just been designed, has a strong commitment to value-based healthcare and focusing on designing a care pathway that focuses all the way from prevention through to acute care. And this is a dedicated new hospital that is actively engaging with the department on changing its approach to care delivery across that continuum. So it's definitely a challenge for us, but what I feel is that there's a dedication to do better, and it's important that we understand that those funding levers are just one component part of an entire system, that hospitals may be controlled by the states, but that is one part of a very complex system. So if we don't work together, if we don't start from a position of outcomes that matter, then we can't, or we will struggle to make those changes around workforce, around care that people can access to try and drive better outcomes for Victoria. So I hope.
I don't want to get you into any political trouble, but it sounds like Victoria's an elite army unit that's not taking orders from the commander and sort of broken through enemy lines to test stuff, and they're hoping to be forgiven after the fact. In the sense that you're really pushing out without that much money in to connect to primary care. Is there some sense of that? I mean, some of these things might be hard to answer, but when you sit around, are you all going, hey, if we can get this far and show that this works, that's one more post in the ground to go to a COAG meeting and help change the funding paradigm a little bit so we can get more continuity of care?
I don't think I can speak too much in relation to that, but what I can say is that this has come from an opportunity to be able to try and support the system. So this is not about replacing or changing, but this is actually saying there is a need and we have to address this need. So what can we do? Yeah. So as a state, we make that decision to do that.
So that's even interesting, Olivia, because you're saying, and I think it's a theme coming through, we need to do what we need to do where the patient is. And you're saying you're pushing outwards. And I know there's a lot of virtual care work going on out of various hospital regions in Victoria. So it just sounds like you're adapting your own system, but it's and this is a statement from me and nothing you have to comment on, but it sounds like you're adapting against the bigger paradigm that exists at the moment, which is, the federal government looks after primary care and to some extent through PHN's allied, and you guys look after tertiary, and you should just somehow talk to each other, but that doesn't happen easily. If you want to make a comment, go ahead, but otherwise I'm happy to leave you and not put you under any sort of pressure to look at that question.
Oh, no, I'm happy to answer to say that whilst, primary care sits with the federal government, I think collaboration and strong collaboration for the need to support outcomes for our communities is something that is on the table always. And so I think from our perspective, that collaboration is the position that we start from and the position that we move from.
Yeah. And do you feel, so once I get you on the spot, I'll keep you on the spot. Do you feel like we're in a time and where we're getting an alignment of roughly on the mainland, and I think Tasmania too, even though it's a different government, we're getting an alignment and a fresh government with fresh impetus. Do you think the timing's right to be better than before for us all to be now having a go at pushing these things and testing boundaries a lot more?
Look, I think it is. And the reason that I think that is because of what we saw and what we have seen through COVID. We have our departmental health summit over the next 2 days, where we've got the entire health sector coming together to have these discussions about how we have care closer to home, how we actually create a vision for Victoria. And Stefan Larson is joining us, and he's speaking around the urgency of change. I think where we are at is at that moment of that urgency for change. I think that we are all understanding that we must continue to harness that momentum that we all established through COVID. We all had a really clear purpose through COVID. We knew why we were all acting together, and we need to just continue and use that drive for the betterment of outcomes for all Australians.
Yeah. There's a long comment to be made there about let's not lose the momentum in COVID, because so much was done, which people didn't think could be done. And I think in a manner, that's why we've got a lot of momentum still. I'm going to just quickly run through a few. There's a few questions here, and I'm going to annoy some people by not asking all of them, because we don't have a lot of time left. And but I do want to touch on the questions and just have them said to the audience and to you as speakers. This one, I think, is to Eric. Was there pushback from the public regarding the use of e-health records when that was introduced? I can come back to that quickly for you, Hans. An obvious one for Hans, which I think maybe we should leave for later, which is the geography of Denmark makes things a lot easier, obviously, for a lot of that strategy. And I think that is clear. But maybe I'll come back to you quickly, Hans, to say geography or not geography, there's lessons there. Comment from Michael Fasher, who's always asking good, interesting questions. Reducing child adverse experiences and increasing positive child experience is the only game in town. He also says wicked problems need local solutions, which I think Rob is touching on. Dr. Niall Johnson, in reforming or reshaping a health system, how do you reassure consumers about the safety and quality of care? And Niall, that's a great question, but if we went to it, we'll definitely be here too long, but that's something we're definitely going to be addressing in Canberra. And if any speakers want to jump in, please do. How can we better educate members of the public? This is from an anonymous, on how they can make decisions of what care they might need. It is clear that a large number of people are going to the ED rather than a local clinic with situations that may not be acute. Why have there not been public health media campaigns or educational materials created? Maybe replacing public fear with self-determination is a pathway we could take. Another anonymous person is asking, having worked in community care in the hospital system, many clients are using emergency departments as GP clinics, which is similar to the question above. And they're just making a point that the rebate for a GP is maybe 1/10 of the cost of that. Is there any movement to change the remuneration schedule for GPs? I think that's a big, long question that we need to deal with over time. Question for Olivia. How is Victorian government funding the outcome-based collaborations that fall outside existing federal government health funding streams and where there is a big gap? And then one from Steve Zannon. What are the chances of funding for wraparound care and an annual care package payment coming out of the May budget? I don't know who would actually answer that, who's on our panel, but maybe Kylie, you'd have a sense. One of the things coming out too is social determinants of care and holistic care, and the sort of stuff that the Treasurer has been talking about in a budget that isn't a budget that's just about money and transactions. That's a social budget, and that's holistic. Now we're going to run out of time because we've got 5 or 10 minutes, so I apologise to those. Just quickly on all those questions, does any of the panel want to take any of those questions or should we leave those and try and get to those later when we get to the summit? No?
Yeah, I agree with you, Jeremy. I think that's why we have the summit, because we've opened the can of worms, and
yeah.
I'm pleased that people have looked at this.
Yeah.
The health literacy one I wanted to pick up on, because we're very fortunate in Australia that the team that wrote the health literacy for the WHO, which was recently launched, are Australians. And health literacy is poor all the way across the health system. I'm saying from the health minister down to the hospital executives, down to ourselves as care providers and others, and most definitely the community. All the way along, there are deficits in health literacy, which is impeding our way forward. So it's a much bigger problem than just telling the patients what they should do.
Okay. So we've just got 5 minutes left here for everyone, and I'm going to return to the question. And I know the question's skewed and to a degree wrong, because it's not all about hospitals, but hospitals gives us a sort of a pivot to be considering a lot of these problems. I want to ask just quickly, can each panel member speak to the idea of if you look at what Denmark's done, and there's very clear evidence base there now. There's some evidence base in a few Eastern European countries. There's evidence base in parts of the UK. There's evidence base in parts of the US around the idea of having regionally managed and funded care, which is sort of counter to our federal system and counter to our funding system at the moment. But it is what, in a manner, has allowed Denmark to move forward. And a lot of the things that Denmark have done, I feel, and I think a lot of people do feel, are clearly relevant to Australia, despite its geography, despite that it's not federated, and despite a fairly sort of different political system and some cultural changes. So this is a quick one for everyone, is, do you think Denmark remains very relevant as something we should be looking at, of how they did it and why they did it, and what part of that applies to Australia? And if you do, what do you think? What do you think is the one thing you might take away for the audience to think about from that Danish, from what you see in the Danish experience? And I'm going to start with lucky you, Leanne.
Thanks, Jeremy. Look, I think it is relevant. And you come back to all the literature, all the evidence, all the guidance from the World Health Organization that the backbone of a high-performing health system is primary care. So, we've got to get the balance better. And I think it's about the conversation about what's modern hospital care look like, and how does it integrate better back into community. And the other thing I think we need to take into the summit, particularly against the backdrop of what this federal government is talking about, care economy. Jim Chalmers is very interested in wellbeing budgets, as we know, and wellbeing economy. Place-based solutions is really important concept for him. So how can we drive transformation through place-based solutions more effectively? We've got infrastructure there, PHNs, LHDs. How can we leverage that?
Yep. Thanks. Kylie, can I go to you?
Yeah, look, I agree with what Leanne has said. We really need to be looking at those place-based solutions, and those relationships between LHNs and PHNs will be critical to that. Measuring what matters is going to be fundamental in all of this. We need to be looking at, well, what does society expect in terms of access to healthcare, and building that and developing that conversation with communities about what that looks like for their community. And again, the LHNs and PHN relationship and how they plan together will be really important to them.
Thanks, Kylie. Rob?
I think we should, in fact, actually invest some efforts in trying to emulate the remarkable efforts that have come from Denmark, and put aside the differences that we've actually got in setting. Looking at and understanding, as Hans has given us a great account of the change process and how they actually did this, because we need to do that, because we have to radically change what we're doing, because people are now being harmed. and the urgency is in fact actually immediate. So we do, and I do like that question. 2 design principles: radical simplicity and co-creation of health outcomes. Yes, let's focus on the desired health outcome and keep it simple.
Yep. And finally, Olivia.
Yeah, look, I think there is absolute opportunity to look at the model from Denmark. It's been proven significantly over these last decades, and I think we're in a position right now where, as a society, we have to look at alternates. We have to look at what's working in other countries and other jurisdictions, and really start turning our minds to the best way we can achieve those outcomes.
Okay, thanks. It's night time. It's 8 o'clock now, through people's dinner time. Everyone has been fantastic. Thank you very much, Hans in particular, for joining in a strange time zone, and for all the other panelists for their contribution. This is a huge topic. It's obviously not just us that's looking at the topic. So please, if you have ideas, send them through to us. And if you can get to the summit, and when the summit does happen in May 3 and 4, it'll be filmed and videoed. So if you can't get to it, we can get it to people after. Thank you for everyone for attending tonight and participating. And hopefully we'll see you May 3 and 4 in Canberra. Thanks very much.